Hi, in this lecture, we will study about the cardiac arrhythmias, the cardiac arrhythmias, and their ECG patterns. Okay, so the cardiac arrhythmias means abnormal rhythms where you have like increased rate of the heart or decreased rate of the heart, which is like very abnormal in nature. So we call it as bradyarrhythmias and tachyarrhythmias. Okay, brady means decrease, tachy means increase. Bradyarrhythmias and tachyarrhythmias, and we need to see the ECG patterns, how we will see them. Okay. So basically, first before going into that, let us see the uh, what are the features that you will see for the cause for the arrhythmias. Okay, so first we are going to look at the causes for the cardiac arrhythmias. So which one includes the first one, that is the abnormal rhythmicity of the pacemaker itself. Okay, so the abnormal rhythmicity of the pacemaker, that is the SA nodal arrhythmias. Okay, so that includes the SA node arrhythmias, nodal arrhythmias, which is like bradyarrhythmias as well as the tachyarrhythmias. We will see the details using the ECG patterns, how they look like in the case of a nodal arrhythmias. Okay, so abnormal rhythmicity. So sometimes if a patient have fever, the temperature can change the rhythmicity of the SA node. That is also one of the reasons. Okay, so we will see what are the other reasons. Okay, or the other cause may be the shift of the pacemaker itself. Okay, the shift of the pacemaker from SA node to another place of the heart. Okay, so mostly if the SA node is not working, the next pacemaker that can pick up is the AV node. The AV node can pick it up. Okay, or it can be from the bundle of hairs, or from the Purkinje fibers, or from the ventricular muscles, or from any part of the atrial muscles itself. Okay, so any of these abnormally behaving tissues which is having a more rate, okay, at that specific time. For example, if the SA node is not working, any other tissue which have a more rate than the SA node will start to fire and cause the abnormal rhythm. Okay, or you can get it because of the blocks at different points that spread the impulse through the heart. Okay, so if there is like a bundle branch block, what happens is when there is an bundle branch block, that may not actually cause an arrhythmia, instead like abnormal patterns in the ECG that we have seen before. Okay, instead of that, sometimes the blocks may be at like Purkinje fibers location, and if there is a block and that tissue is like out of phase. Okay, so we normally call it as the out of phase depolarization or out of phase repolarization. In that scenario, they will send the impulses. If they go in out of phase from the normal tissues, then they can start the spread of the impulses and cause the abnormal rhythms. Okay, or sometimes the abnormal pathways of impulse transmission through the heart. An example is the bundle of Kent, which causes the WPW. Okay, we will discuss about the WPW later. So that is the bundle of Kent that causing the abnormal rhythms. Okay, or you can have the spontaneous generation of spurious impulses in almost any part of the heart spontaneously. Okay, it can happen because of the abnormal behavior, or some the cell will behave, the plasma membrane may be like damaged, and the cell will the ionic, the cations especially can enter and start causing the abnormal rhythms. Okay, so what is the basic mechanism? Okay, so either it is due to increased automaticity, okay, or it is due to the triggered automaticity, or the mainly it is due to the re-entry phenomenon, the circus movement. Okay, so this is very important. The circus movement is like classically, like always they ask you in the exam. Okay, so let's discuss a little bit more like details of what is the meaning of this circus movement or the re-entry phenomena. Okay, so in order to have a re-entry phenomena, as you have seen over here, okay, this is like a action potential. Okay, the action potential is coming, okay, from the one location, and this action potential is traveling down to the cardiac tissue, but because of a damaged tissue it is unable to pass through down like this. Instead they bifurcate into two. Okay, but can they come and re-enter over here? No, because by the time it is coming over here, the remaining area, the point at which it need to enter is already depolarized, so they are in the refractory period. So the point over here, you can see it comes and then it bifurcates and then go, okay, and then it bifurcates, then it goes here, but it cannot enter here, or this cannot enter over here, okay, because these points are depolarized already and they are in the uh, refractory period. So what will happen to this impulse? Instead of going on both the direction, they will come down. Okay, so this is good. Okay, if it comes down, it is normal, it does not create any problem. Okay, only the issue is there is a scar tissue from the old MI or something, so that is why you get a bifurcation and just going on. But sometimes what happens is you get like a, for a fraction of a second, the sum of these tissues, you can see over here, some of this tissue that is present over here, for a fraction of a second, they are not able to conduct the impulses. When they are not able to conduct the impulse for a fraction of a second, what happens? This bifurcation onto this side will not be passing down. Okay, so why this tissue undergone like a partial of a second, like a unable to conduct, maybe due to like a lack of oxygen, like a transient ischemia, which has been like caused like a for a fraction of a second in ischemia, and that tissue was not able to respond to the impulse that was coming, and the impulse got blocked over there. Okay, so this block is like not permanent. Okay, so this block is for a very short duration of time. Okay, so that short duration of the time, the impulse was not able to bifurcate and pass through. So now what will happen? This impulse that was like coming from this side can start entering over here, but by the time the impulse is reaching over here, what happened to the ischemia over here? That has been disappeared. The ischemia over has been disappeared. So now what will happen to this impulse? The impulse will start to move on. Okay, and then by the time it reaches here, the refractory period is over here. So they keep going round and round, round and round, round and round, like that. So what happens? Not only it goes round and round, it starts sending the impulses from this location to all other parts of the heart. Okay, so it will be like going round and then keep on sending impulses from that spot to all other parts, and this creates arrhythmias. Okay, this is one of the classical cause for major arrhythmias. Okay, so please make sure that you remember this point. Okay, this point is being remembered very thoroughly. Okay, so now moving on. Okay, let's see the first. So basically we need to see the rhythm problems in the SA node. Okay, in the SA node you need to see, in the AV nodal problems you need to see. Okay, and in between the SA node and AV node, you have to think about the atrial arrhythmias. Then you need to study about the ventricular arrhythmias. Okay, so basically let us start. So one, okay, and then the two, then the three, and then the four. Okay, so these are the four locations where the arrhythmias can originate. Okay, so let's first start with the nodal arrhythmia, so the abnormal sinus rhythms. Okay, so the abnormal sinus rhythm. So first one is the sinus tachycardia. Okay, sinus tachycardia. Here whatever you observe, you will have all the normal. You have the P wave, you have the normal QRS T wave. Okay, and again the again the normal P wave, and again the normal QRST. Okay, so it will be keeping on going like this: P, Q, R, S, T. Again P, Q, R, S, T. But what happens? The R interval, the distance between one R to the other R, or the rate will be more. Okay, so that's what happens. It does not cause any other issues over here. Means does not, the pattern of the ECG is not changing, the sinus rhythm is being there. That means the SA node is working, but it is working with a faster rate. Okay, so the heart rate is very close to each other. Okay, so you can see over here the rate is like very close to each other, right? Okay, the heart rate is like only showing like say maybe like 10 small boxes. Okay, so when it is 10 small boxes, you know how to calculate the heart rate, we have studied before. Okay, so it will be like 1500. If it is 10 small boxes, then it is 1500 divided by 10, which is like 150. Okay, so the rate is 150. Okay, so in this example the rate may be approximately 150, which is considered to be a higher rate. Okay, so that is what you have to understand in a sinus tachycardia. So examples of the causes is like abnormal blood supply to the SA node, or maybe the temperature. If the patient is having like too much of temperature, that may be a cause for sinus tachycardia. Okay, so another thing is sinus. The next thing is that we need to say is the sinus bradycardia. Here also you have all the waves like P, Q, R, S, T, and then again P, Q, R, S, T. All the waves will be like regularly being seen. Okay, but the problem is again the rate. You can see the distance between the RR. Okay, so here you can see like there is how many big box? 1, 2, 3, 3, 4, 5, 6, 7. 7 big boxes. So the another equation that we have studied, if you have like 7 big boxes, so you have to divide that by the 300. Okay, so 300 divided by 7. How much would be the rate? So it will be around 50 beats per minute, right? Okay, less than 50, or you can say like 40 something approximately. Okay, so less than 50 beats per minute, or like approximately 40 beats per minute. Okay, so that is like very the rate is like very low. Okay, so that is why we refer that as the sinus bradycardia. Okay, so classical example where you can get sinus bradycardia, where the sinus SA node is working good, but the rate is very low. That is in the athletes. Okay, because they are trained, because they are trained and their cardiac output is already being enhanced because of the increased cardiac muscular strength. Okay, the strength of the cardiac muscle and the size of the cardiac muscle will be already enhanced, so their stroke volume will be already enhanced. So in order to meet the normal cardiac output, which is stroke volume multiplied by the heart rate, so in order to, because the stroke volume is higher, you need to reduce your heart rate. So that's why these athletes will have a higher vagal tone, and because of the higher vagal tone, they will have a decreased heart rate. Okay, okay, so that is the reason for the bradycardia in athletes. Okay, so another condition is the sick sinus syndrome. Okay, where you can see sinus tachy and brady syndrome. That means tachy and brady together. That means for some time the rate will be more, and after some time the rate will be slow. Okay, or lower. Okay, so this is called as the sinus tachybrady arrhythmia. Okay, so especially due to ischemic injury. Okay, when the blood supply to the SA node is having a problem. Maybe you might have studied like about the blood supply to the SA node. Okay, so please go and revise like the blood supply part that you have studied in your anatomy. Okay, the blood supply to the SA node. What are the arteries that can supply to SA node? So if there is a block in that, you can get a sick sinus syndrome. That's normally how they ask you in the exam. Okay, they will show you a sick sinus syndrome and then ask you what is the problem. Okay, so but you should not confuse the sick sinus syndrome, okay, with sinus arrhythmia, which is referred to as the sinus arrhythmia, which is actually it has to be the sinus respiratory arrhythmia. Okay, respiratory arrhythmia. So the sinus respiratory arrhythmia means the respiration, especially during inspiration. Okay, during inspiration, what happens to the heart rate? There will be increase in heart rate. The reason for that, inspiration will cause a decreased vagal tone. Okay, the vagal tone will be decreased. So when the vagal tone is decreased, what happens? It causes an increase in the heart rate. Okay, so if you have a period of like inspiration, this is the period of inspiration, and this is the period of expiration. You will see here the R waves are coming faster, here the R waves are coming slower. Okay, so this is how you will see. So the R waves are coming closer over here because of the inspiration. That means the rate is high. The R waves are coming slower. That means the rate is like slower over here. That means during the expiration. Okay, the expiration, the rate will be slow. Okay, decrease in the heart rate. But again, here during the inspiration and expiration, does it go beyond the normal limit of the heart rate? No, it's within the normal limits, but slightly more during the inspiration and slightly less during the expiration. So that is how you can distinguish this from sinus tachybrady syndrome or the sick sinus syndrome when there is an ischemia. In those conditions, what will happen? It will go beyond beyond the normal limit. Okay, so that is the problem over here. Okay, so now another condition is what, when you have as a block. Okay, suddenly if there is a block in the SA node, what happens? You will have a sudden drop of the P wave. That means the impulses are not being spread through the atrium, and then suddenly what will happen? It will be picked up by the AV node, and the AV node will start to fire. So you start to get the QRS complexes, okay, but you will miss the P waves. Okay, you don't see the P waves. So over here there is no P wave, over here there is no P wave. Okay, so these P waves in the after the block will be missing because there is no impulses that is transmitted through the atria. So the impulse will be now generated from the AV node. Okay, okay, but what will happen when the AV node is making the rhythm? You can see over here the rate is slower. Okay, because the SA node was having a much higher rate, whereas the AV node, when it is being conducting, it will have a lower rate. Okay, hope you understood that point. Okay, now let's move on. So we need to study about the SA nodal arrhythmias, AV nodal arrhythmias, atrial arrhythmias, and ventricular arrhythmias. Okay, so these are the major ones that we need to study, the 4 locations where you can have the arrhythmias. Okay, so now we have finished with the SA nodal problems. So let's continue with the atrial arrhythmias. Okay, atrial arrhythmias. Okay, so now the problem is the atrium. Okay, problem is in the atrium. Okay, so we don't have a condition like where we have like atrial bradyarrhythmias. So atrial bradyarrhythmias are not due to the atrial problem, so it is due to the SA nodal problem. Okay, so if the SA node is not firing, again the atrial contractions will be slow, but that is not a major concern, because the major concern for a physician is always to have the ventricular rate being maintained. Okay, so atrial slowing down or the atria beating fast is also not a problem, provided if the atrial contractions pass down to the ventricle, it becomes a serious issue. Then it leads into supraventricular tachycardia. And if it is not like a continuous, we sometimes refer to as a paroxysmal supraventricular tachycardia. So that is a major concern. So that is what is mentioned over here. Okay, the management. So what should be the management of this? Slow down the AV node to prevent the paroxysmal supraventricular tachycardia. Okay, so how to do that? Whenever there is an atrial arrhythmia, atrial tachyarrhythmia, and you don't want to spread down to the ventricle to cause the ventricular problem, so you have to slow down your AV node. Okay, so that the AV node does not keep passing down all these abnormal rhythm that is not coming from the abnormal rhythms that is not coming from uh, the SA node. Instead it is coming from the atrial wall, and it is going down through the AV node, so you need to slow down. So what are the drugs that we can use for slowing down the AV node? You can use calcium channel blockers, beta blockers, digitalis, okay, by increasing the vagal activity. So we have discussed before how the digitalis can increase the vagal activity. Okay, okay, so the main, what are the major forms you need to worry about in the atrial arrhythmias? Atrial arrhythmias, you have atrial tachycardia, okay, up to like 220 beats per minute, and then atrial flutter, okay, so which is like 200 to 350 beats per minute, and atrial fibrillations, which is like 300 to 500 beats per minute, which is very high. Okay, so you can see the major things that you need to understand, like either you can get like a simple extra systole, okay, atrial systole, just like an additional P wave. You can see over here an additional P wave, okay, just like a P wave is there, and additional to that, like immediately after the P wave or one over the other, you have like P and P like coming together. Okay, that is like just an extra systole. There is no much concern in the clinical scenario for that. Okay, so atrial tachycardia, okay, all the rhythm is normal, every P wave is like immediately followed by QRS. Okay, the QRS is there, so the rhythm itself is like high. Okay, to atrial tachycardia, okay, which is not also not good. Okay, now if it goes to atrial flutter, okay, how that it look like? It looks like a flutter waves. We call like this one, like this waves. Okay, so you can see sometimes referred to as the F wave. Okay, otherwise referred to as the sawtooth pattern. Okay, sawtooth pattern. Okay, so this is important. Once you start seeing the sawtooth pattern, it's atrial flutter. But if it goes down again to fibrillation, you can't see the flutter waves. Okay, you can't see the flutter waves. Instead, between a, this is like a QRS complex and another QRS complex over here, what happens to the waves? It looks like wavy. Okay, there is no constant P wave. Instead, the wave is the line is like wavy line. Over here you can see between one QRS complex and the other QRS complex, you can see the wavy line. Okay, whereas in the atrial flutter you are seeing the F waves. This is F waves, the flutter waves, that is referred to as the sawtooth. Okay, so that is the major differences between the atrial flutter and the atrial fibrillations. Okay, so you can see over here the atrial fibrillation. Okay, so the chaotic and erratic baseline with no discrete P waves. Okay, no discrete P waves in between the irregular QRS complex. Okay, so irregular heartbeat. Okay, so that is why it is like referred to as the paroxysmal supraventricular tachycardia. Okay, so irregular base, and the each QRS complex will come on a separate time gap. Okay, and most common risk factors include hypertension and coronary artery disease for the atrial fibrillation. Okay, and can lead to thromboembolic events, because when the atrium is beating too fast, what will happen? The chances for the blood clot to happen, and the blood clot will move down to the ventricle, and from there to the circulation. Okay, it can go to the circulation and can block anywhere. Okay, and particularly if it goes into the brain part and can block in the brain and can lead into stroke. Okay, so you have to include in the treatment what? Anticoagulation and to control the rate. Okay, rhythm control or cardioversion. So either you may have to remove those abnormal spots from which the atrial fibrillation is occurring. Okay, so another is the atrial flutter. So a rapid succession of identical back-to-back atrial depolarization waves. Okay, so the identical appearance is called as the sawtooth appearance of the flutter waves. Okay, so treat similar to that of the atrial fibrillation. Okay, definitely treatment is the ablation. Okay, catheter ablation. So you put a catheter and remove the spot from which it is happening, or the remove like the whole atria, maybe if it is from right atria or from the left atria. Okay, so we don't need like the atria is not the major chamber, so that is why ablation is possible, but the ablation to a ventricle is never done. So for the atria you can ablate it. Okay, you can stop the working of the atria and cause the damage to that tissue on purpose and stop the abnormal rhythm occurring from the atria, because it can spread down to the ventricle. Okay, so you can see over here the sawtooth patterns. Okay, these are all the different F waves in this waves. Okay, so that's about the atrial arrhythmias. Okay, okay, so now next one is the reasons for these arrhythmias. Okay, so now we have previously seen the re-entry phenomena. Okay, the re-entry phenomena. So if the re-entry phenomena is happening from one spot and just going round and round in the atria, okay, that will cause atrial flutter. That's why you are getting faster waves in the F waves. But instead, if the re-entry phenomena is happening at this spot and this spot and this spot and multiple spot, what will happen? The waves will come from here and here and then here and then here, and then it gets cancelled out. So the ECG leads cannot get picked up. So what will happen? You just see a wavy line in the ECG. Okay, you just see a wavy line, wave pattern in the ECG. You don't see like a flutter wave. So if the re-entry phenomena is happening from one point, then it is called as the atrial flutter. The atrial flutter, the most commonest reason for the atrial flutter is the re-entry phenomena happening from one spot. Whereas for the atrial fibrillation, it is from multiple points. Okay, from multiple locations in the atrium, it is having that problem. Okay, good. Okay. So that's about the atrial patterns. Okay, the atrial flutter and atrial fibrillation is very important for your exam point of view, and the major concern is paroxysmal supraventricular tachycardia, which need to be prevented in this scenario. Okay, so now going to the AV node. So we have done with the SA nodal problems, and then with the atria. Okay, so we finished on those part. Now we have to finish with AV nodal problems and the ventricular problems. Okay, so AV node have two problems. Either you can get like AV nodal bradyarrhythmias, or you can get AV nodal tachyarrhythmias. So first let us start with the AV nodal brady. Okay, so the bradyarrhythmia, so that is referred to as the heart blocks. Okay, so whenever you have the problem in the AV node, that is there is a block in the AV node, then we call it as a hard block. So simply saying it is a hard block, so don't confuse whether it is a left bundle branch block. No, when they say, when the question or somewhere like it is mentioned as a hard block or like a junctional block, okay, so simply as like a first degree block or a second degree block, okay, it is all being referred to as AV nodal block. Okay, if it is due to like a left bundle branch block or a right bundle branch block, then we have to specify that as right or left or a branch block or something like that. Okay, otherwise if they simply say straightforward as block, hard block, it is AV nodal block. Okay, good. Okay, so let's see, there are three differences. One is the first degree, second degree, and the third degree. Okay, so in the first degree, what happens, the AV node is able to conduct all the impulses that is coming to the AV node from the SA node. SA node is working good and is sending the impulses to the AV node, but the delay in the AV node is more than the normal. So that is the first degree. In the second degree, what happens? The impulse is coming from the SA node and it is reaching to the AV node, and some of the impulses are passing down and some of them are not being passing down. So that is your second degree. In the third degree, what happens? SA node is sending the impulses and none of those impulses is going down through the AV node. AV node is completely blocking all the impulses that is coming from the SA node. Okay, and none of those impulses that is coming from the SA node is passed down from the AV node to the ventricle. So that is third degree heart block. Okay, so now let us see what are the details of these blocks. Okay, so in the first degree heart block, in the first degree, okay, what happens, all the impulses are passed down but with a delay, and this delay in the AV node is represented by the PR segment. Okay, so what will happen to the PR segment or the PR interval? What will happen to it? It gets prolonged. So you will see a prolonged PR interval or a prolonged PR segment. Okay, so normally it is around like the PR segment is around like 2 to 2.5 boxes. Okay, so but what happens here, the small boxes that you need to count, but over here you can see the small boxes that is covering the PR segment is like around like 5. Okay, so which is now more than double the normal. Okay, so or even if you take the PR interval is normally about 0.16 seconds, which is now doubled over here. Okay, more than doubled over here. So the PR segment has become more, PR interval has become increased. Okay, so this is an indication for the first degree heart block. So when there is a first degree heart block, that means there is a prolongation. Okay, the prolongation. Okay, so now what about the second degree? Okay, so we have finished with the first degree. Let's see about the second degree heart block. Okay, so second degree heart block. Okay, so this is the second degree heart block. You have two different types of second degree heart block. Okay, either it can be called as the Mobis 1 or the Mobis 2, or sometimes the Mobis 1 is referred to as the Wenke back and the Mobis 2 is referred to as the non-Wenke back. Non-Wenke back. Okay, so Wenke back and the non-Wenke back, or you can refer to as the Mobis 1 and Mobis type 2. Okay, Mobis 1, Mobis type 1 and Mobis type 2. Mobis 1, Mobis 2. Okay, so the difference over here, if the so the main thing, when it is called as a second degree, if all the impulses that is coming from the SA node does not pass it down, so you have the P wave and then you have the QRS complex, okay, the T wave, and then you have a P wave, and then this impulse is not transmitted down, but the next impulse is now transmitted down. Okay, so you are missing a QRS complex over here. You miss a QRS complex over here, that means there is a drop. Okay, there's a drop of the impulse, the one of the impulse is not passed down, so then we refer that as a second degree. Now what are the two different types of second degree? This one is like a normal type of the second degree, but if you see a PR interval prolongation, okay, prolongation, you have the next P and next you have a prolonged P. Okay, you have the T and then you miss it. Okay, then you miss, then there is a miss of the QRS complex. So what happens here, you have a normal PR segment, okay, the normal CM segment, and then you have a prolonged PR segment. Okay, over here you have a prolonged, so it progressively, so there is a progressive PR interval being like prolonged, then we call that as a Wenke back or the Mobis type 1. Okay, so that's the major differences between the second degree type 1 versus type 2. Okay, so there will be progressive lengthening of PR interval until a beat is dropped. Okay, so a P wave not followed by a QRS complex. That is basics for the second degree. So in second degree there will be a P wave which is not followed by a QRS complex. Okay, so this is usually asymptomatic but variable RR interval with a pattern regularly irregular. Okay, so you will see over here. So this PR1, okay, is smaller than that of the PR2 and is smaller than that of the PR3. Okay, so you can see the progressive increase in the PR segment and then there is a drop in the QRS complex. Okay, whereas in the non-Wenke back, okay, please be careful with this Wenke back because that is the normal terms mostly used in your exam. Okay, so don't forget, like, the Mobis name as well as the Wenke back name. Okay, keep them in the brain. Okay, so here also there will be dropped beats that are not preceded by a change in the length of the PR interval. Okay, so may progress to third degree block. So this is more commonly progressing into third degree block, often treated with pacemaker. Okay, so here you can see the PR interval are same, and then you suddenly drop it. Okay, so there is a sudden drop in the QRS complex. Okay, good. So that is the major differences between the first degree, second degree, and in the second degree Mobis 1, Mobis 2. Now let us go into the third degree, okay, which is like a complete block. None of the impulses are transmitted down from the atrium into the ventricle. Okay, from the SA node through the AV node, nothing is going. So the atria and ventricles beat independent of each other. Now how does the ventricle beat? Okay, so ventricle beat with its own rate. Okay, whereas the atria beats with the synodal rate. Okay, so the P waves and the QRS complex are not rhythmically associated, and the atrial rate will be always higher than the ventricular rate. So usually treated with pacemaker, can be caused by Lyme disease. Like in microbiology, you might have studied about the Lyme disease, right? So that can be one cause for this third degree heart block. Okay, so damage to the AV node. Okay, so you can see over here, if I draw you like separately over here. Okay, so you will have the P, okay, the rate of the P going at the regular intervals like this. Okay, and the Q, let me take another pen. Okay, so the rate of the P is like normal, like, right, but the QRS complex will come irregularly over here. You have the QRS maybe immediately after the P wave, or you may have like the QRS complex like immediately before the P wave, etc. So you can see the rate of this is much higher compared to that of the rate of the P and P. Okay, so normally the P to P, the rate will be like around like approximately like around 70s or 80s. Okay, it can be like even up to hundreds. That's within the normal range. Whereas the RR interval, like the RR interval rate, if you calculate the RR interval rate, that is the rate of the ventricles beating, it will be less than 40. Okay, so less than 40. So that is what we see in the third degree heart blocks. Okay, so in the third degree heart block, we use certain terms to describe this process. Okay, it's not that immediately as soon as you have a drop, the QRS will start to appear. As soon as the AV node stops functioning, you cannot get the QRS immediately. Okay, so what happens over there? Suddenly there will be a block of the AV node. AV node suddenly blocks and does not send any impulses down to the ventricle. Okay, so now what will happen? The ventricle does not get any impulses and the ventricle stops contracting. When the ventricle stops contracting, what will happen? There is no blood supply. The ventricle is not contracting. There is no stroke volume or the cardiac output. No blood supply to the brain. The person will faint. Okay, the person will faint. Once the person faint, okay, what happens? By that time, the ventricle is like does not receive any impulses from the AV node, because SA node is conducting, but the AV node is not able to transmit it down. The ventricle produces its own action potential, especially if the bundle of His is normal. Normally it started from the bundle of His. Okay, bundle of His or the bundle branches or the Purkinje fibers will start to fire, and then the ventricle will start to contract. So what will happen? Now the blood will go to the brain and the person will come back to the normal state. Okay, even though the rate is very slow, but the dizziness or the fainting might have gone back. Okay, the person is receiving blood, so because it happens immediately. So all these phenomena associated together, okay, AV nodal block, and then the person faint, and then the ventricle escape from this problem, and then starts to beat and in a slower rate, and then the blood flow to the brain is retained, and then the person wake up. Okay, so this all phenomena together is what is referred to as the Stokes-Adams syndrome. Okay, which includes this ventricular escape. So due to lack of blood supply to the brain, person with complete heart block may faint. Okay, but ventricles recovers from the block and beats at the idioventricular rhythm, which is much slower, which is about less than 40 beats per minute. Okay, so this is called ventricular escape. Okay, so you have to remember about these phenomena like the Stokes-Adams syndromes, ventricular escape, etc., that is associated with your third degree block. Okay, so maybe in this ECG you can see P waves are coming very regularly. Okay, whereas the QRS complex is like much away from them. Okay, and there is no relation between the QRS complex and the P wave. Okay, but the regularity of the QRS complex and the regularity of the P wave is maintained. Okay, because P wave is under the influence of the SA node and the ventricle is under the influence of the maybe the bundle of his or from other Purkinje fibers or the bundle branches. Okay, so they are acting as the pacemaker. Mostly the bundle of his act as the pacemaker and do the conduction. Okay, so that is what happens. So you can see there is a complete heart block. Atrial rate is around like 100 and ventricular rate is around 40s. Okay, so normally below 40, so in the range of 40 you will get it. Okay, so that is what happens in the complete heart block. Good. Okay, so the AV node problems are two types. Okay, one is the blocks. Okay, that is called as the brady. Okay, the blocks means decrease in heart rate, and this is referred to as the bradyarrhythmias. Okay, this is a part of bradyarrhythmia. Whereas you can get tachy. Okay, due to AV nodal problems. Okay, tachyarrhythmias. Okay, so now let us look into the tachyarrhythmias that is happening at the junction AV node. Okay, so the most common one, very important for the exam, is the WPW, which is like the abbreviation for Wolff Parkinson White syndrome. The Wolff Parkinson White syndrome. Okay, so in the Wolff Parkinson White syndrome, what happens? There is anatomically a problem. You have a bundle of Kent. Okay, so what is happening? It is bypassing the AV node and causing the faster conduction. Okay, it's not faster conduction through the AV node, but it is bypassing. So AV node have the ability to hold the action potential and allow the atrium to finish the contraction, and then the impulses will go down to the ventricle. But now what happens? This delay is not being maintained. Okay, so that's why, because you have an additional bundle that is called as the bundle of Kent. Okay, bundle of Kent. Okay, so let's see what is happening in the Wolff Parkinson White syndrome. Okay, so this is the most common type of the ventricular pre-excitation syndrome. Okay, most common type. Before excitation, the ventricle is getting activated. So abnormal fast accessory conduction pathway from the atria to the ventricle. The most common one is the bundle of Kent. Okay, bypasses the rate slowing AV node. Okay, so the major role of the AV node is to slowing down. Okay, because we don't want the immediate impulse coming from the SA node immediately to the ventricle, because we want time given for the atrium to complete the contraction and then the ventricle should start contracting. But now that delaying is like not there because of this additional bundle. So ventricle begin to partially depolarize earlier. Okay, and characteristic delta wave with widening QRS complex and shortening of the PR interval or absent PR interval will be seen in the ECG. Okay, so this pattern that you see over here is referred to as the delta wave. So what happens? Because there is no delay, the delay is shown by the PR interval. Immediately after the P wave, what happens? You get the QRS complex like this. Okay, so this, instead of like having the PR segment over here, what is happening? It is immediately going into the QRS complex. So this part of this wave is referred to as the delta wave. This is the delta wave. Okay, being referred over here as the delta wave. Okay, going up. Okay, now there is like a very less commonly asked one, that is the LGL. For the exam point of view, very rarely asked LGL. This is also the same problem over here. Okay, there is additional bundle that is causing the conduction to happen. Okay, the problem over here you have the SA node, you have the AV node and the bundle of phase, and then it is bifurcating into left and left, but right bundle band. So from the SA node, you get it, go to the AV node, and the impulse goes down, but you have an additional bundle. So normally this additional bundle is a muscle fiber which goes and connect to the septum muscles. Okay, so there will be like septal muscles around here, they connect to the septum muscles. Okay, and then you get the conduction. But sometimes what happens, instead of going to the septal muscles, you have some bundles that is going and connecting directly to the bundle of phase. So the impulses then transmit like it's just faster. Okay, it's not that you have a widened QRS complex. Okay, so you can get this problem without a wider QRS complex, without a wider QRS complex. Okay, so you get the LGL. So immediately after the P wave, so you can see over here, immediately after the P wave, this is supposed to happen like this. Instead of that, immediately after the P wave, you have the normal QRS complex. Okay, whereas in the case of WPW, you have the immediately after the there is no PR, but the QRS complex is wider. Okay, so this delta wave phenomenon, this is called as the delta wave. This delta wave is not seen in the LGL, even though you have the bundle of Kent and then or similar structures, the additional bundle that is connected, but it is immediately going down to the bundle of his and making it fast conduction to happen. But that is the normal QRS complex you get. Okay, but don't worry about the LGL syndrome, okay, much, but it's very important to understand the Wolff Parkinson White syndrome or the WPW syndrome. Okay, good. So make sure you learn more about the WPW syndrome, and that is more often asked in the exam. Okay, just to in case if they ask about the LGL, to understand the difference. That's it. So if there is a PR segment absent, then you have to think about WPW, okay, or an additional bundle being present over there. That's what happens. Okay, so we are now done with synodal problems, atrial problems, atrial arrhythmias, and the AV nodal arrhythmias. Now we are left with the ventricular arrhythmias. Okay, one of the important point that you can note over here is the ventricular premature beat. Okay, this is like not like a clinically very important point. Okay, but illustrates the compensatory pause. Okay, so whenever you get like an additional beat, okay, for example, the rate is going like this, like this, like this, like this, like this. Okay, now you're supposed to get it like this, you're supposed to get it like this, but here instead of getting it here, what happened, you got it earlier. Okay, let me show it once more. Okay, you got it, you got the beat faster here, you got it, and then the next beat came immediately. Okay, an abnormal beat came. Okay, so the next QRS complex will be at the same time as normal, so it matches over here, see, and then this pause that has been created over here is called as the compensatory pause. Okay, because you got an extra beat over here, so this is called as the ventricular premature beat. Okay, so you got the ventricular premature beat and then you got a compensatory pause. Why? Because during that period, okay, when there is an extra systole happening, you have that the heart has gone into a different state, and it allow the time, okay, for the calcium to go out, and then the new wave to start, because the next SA nodal activity will be silenced during that time. Okay, because the heart will be in a refractory period because of this extra systole. That's why the SA nodal rhythm that is coming on the middle of it is skipped, and then goes again and come back in the next SA nodal rhythm. Okay, so that is missing. Okay, this rhythm that is being missed over here. So this SA nodal activity is happening, but it cannot be represented on the ventricle because the ventricle was at that time on a refractory period, cannot take up that activity. Okay, so you got a compensatory pause. Okay, so that is the meaning of the word compensatory pause. Sometimes asked in the exam, what is this compensatory pause and why you get a compensatory pause whenever you have a ventricular premature beat. Okay, and this is not, the ventricular premature beat itself is not like a very important clinical phenomena. Okay, but it may indicate a future problems. Okay, it may indicate the ventricle is like having some abnormality. Okay, now what are the other ventricular arrhythmias or the points that we need to remember. Okay, so you can get like the paroxysmal ventricular tachycardia. This is due to paroxysmal is mainly the meaning of the word paroxysmal means what? Coming and going. It just come and go. Okay, it's not like continuous tachycardia. It comes and then go. Okay, so in that you can see very regular pattern. Okay, the QRS complex is like very regular. Okay, you have the very regular QRS complex, but what happens? Very regular rhythm, but there is no other waves. Okay, just like one, like a big waves. Okay, which is like just a pattern. There is no P wave, T, or any other wave, just like bigger waves. Okay, and the rate you can see much closer to each other. Okay, they are very close to each other. Okay, very close to each other. Good. Okay, and that is the paroxysmal supraventricular tachycardia, or a paroxysmal ventricular tachycardia. Okay, another one is the torsades. Okay, the major classical cause for this is a decreased magnesium or a prolonged QT interval. So prolonged QT interval can lead into torsades. Okay, so there are some drugs that can prolong, like some antiarrhythmic drugs, some antibiotic drugs, which you will learn more about in the pharmacology, which are the drugs that can prolong your QT interval. Or there are some genetic diseases, okay, which causes the sudden cardiac death. Okay, so some genetic diseases can also cause us torsades. Okay, so torsades means what? This like abdominal pattern that you see, it's going on one direction and suddenly it will start going in another direction, and it goes up and then it goes down. So this is like referred to as the toppling of the points. Okay, this is referred to as the toppling of the points. Okay, so it's going up down like that. So toppling of these points is referred to as the torsades. Okay, the torsades. The major cause for that torsades is what? Decreased magnesium. Okay, and prolonged QT interval. Prolonged QT interval. Okay, so if a patient is showing prolonged QT interval, they have a high risk to go into torsade. Or if a drug or something is causing a decrease in the magnesium, they can go into torsades. So one of the classical treatment approach for the torsades is to provide magnesium. Okay, or a decrease in potassium can also cause torsades. Okay, so these are the causes for the torsades. But important, like when you see a wave pattern, you have to remember it is a torsade. Okay, so look at the image and understand this is a torsade and not the ventricular arrhythmia or the ventricular tachycardia or a VFib or the ventricular fibrillation, etc. Okay, so very classically you might have heard about this term called as the ventricular fibrillation, right? Okay, so what is the ventricular fibrillation? Again, the rate is very high and completely irregular pattern. You can't like identify anything. Okay, and there is no specific pattern. It's like wave impulses going like uh, without any control. Okay, no discernible rhythm is seen that. Okay, so in the ventricular fibrillation, a complete erratic rhythm with no identifiable waves. Okay, so it's a fatal arrhythmia. Okay, so what you have to do? Immediate, without immediate, it will become fatal. So you have to give immediate CPR and defibrillation. So defibrillation means what? You suddenly pass a discharge. Okay, suddenly give, like the instrument, right? For you might have seen, like okay, so you provide with a high volt, okay, for a few milliseconds. Okay, so holding it for the pressure and then give it and then provide the high voltage, so that all the voltage in the heart goes into the same level, and then the heart will start back again. You can see it starts back again. Okay, so it's just like trying to correct it. Okay, so that's what we have to do for the ventricular fibrillation. Okay, it's important to identify the ventricular fibrillation, and the only approach is like the defibrillator and give the CPR, because it's very fatal. Okay, once you have, it has to be immediately corrected. Okay, now so those are the arrhythmias that we have seen. Okay, so we have seen about the synodal arrhythmias, synodal tachy and brady. Atrial arrhythmias, mainly you have seen two things: flutter and the fibrillation. Then we have seen AV nodal problems. AV nodal problems are divided into two: brady and the tachy. So the brady includes the blocks, the heart block, first degree, second degree, and third degree. Second degree, again, two different types: Mobis 1 and Mobis 2, or the Wenckebach and the non-Wenckebach type. Okay, and then going to the third degree also you have seen. Okay, and then the AV nodal tachyarrhythmias. The tachyarrhythmias, the most important tachyarrhythmia at the level of the AV node is bypassing the AV node with bundle of Kent, that is the WPW. Okay, so remember about the WPW. Then we have studied about the ventricular tachyarrhythmia. So you can get supraventricular tachyarrhythmia, paroxysmal supraventricular tachyarrhythmia. You can get like torsades points due to the prolonged QT interval or decreased magnesium, or some drugs that can cause prolonged QT interval, or some genetic diseases that can cause prolonged QT interval, all can cause torsades. Okay, treatment approach is mainly to provide magnesium. Then we have studied about the ventricular fibrillation. Okay, the treatment approach is mainly using the defibrillator and giving the CPR. Okay, so one more additional point just I want to add to this arrhythmias over here, and then to conclude the ECG topic is the hypokalemia and hyperkalemia. What happens to the ECG? How to identify the ECGs from by looking at the the potassium levels, what happens to the potassium levels, and look at the ECG, what are the changes that happens. Okay, so hypokalemia and hyperkalemia. So the normal value of the plasma potassium level is about 4 to 5. Okay, 4 to 5.5. Okay, so now what happens? The normal PR interval is 0.16, QRS is 0.06 seconds, QT interval is the 0.4 seconds. Okay, so and the normal assumed heart rate is somewhere around 60. Okay, so these are the normal values. Okay, in this normal tracing what you have observed. Okay, so now going down to hyperkalemia. What happens in hyperkalemia? The immediate effect, okay, as soon as the plasma potassium levels goes high, is like the tall T waves, tall and slender. Okay, it's not like widened, it's tall and slender T wave. Okay, because the potassium is very much important for the repolarization phase, and then the repolarization is represented by the T wave, and you start to see the problems in the T wave. Okay, so the plasma potassium level is 7. Okay, so the PR and the QRS are within the normal limits. Okay, so this is a higher value, and very tall slender peaked T waves are now present. Okay, so that's what happens in hyperkalemia, but not like an extreme hyperkalemia. But when it goes to extreme hyperkalemia, like it goes to 8.5, okay, to the level of 8.5, from the range of like 4 to 5, it goes to 8.5, which is like considered to be a higher. Okay, now what happens? There is no evidence of the atrial activity. Why? Because it's not that the atria is not working, but atrial activity has been taken up by the QRS complex itself. So you can see it is taken up, and you can see a wide QRS complex over here, the wide QRS complex, and you might see a bizarre, okay, bizarre in the QRS complex. Okay, so the QRS complex has become much wide. Okay, and QRS complex is broad and slurred, and the QRS interval has been widened to about like 0.2 seconds. The T wave remains tall and slender. So further evaluation of the plasma potassium level may result in ventricular tachycardia and ventricular fibrillation. Okay, so that is the reason for it can lead into ventricular tachycardia and ventricular fibrillation if it further increases. Okay, so initially what you see, tall T wave. Later on you will see the tall T wave with the prolonged QRS complex, and there is no activities for the atrium being represented because it has been so wide. Okay, so the QRS complex becomes wider. Okay, now let us go into hypokalemia. What happens in hypokalemia? Okay, so if it goes below 4, okay, just below 4, like around 3.5, the hypokalemia effect can be shown in the ECG. Okay, so what happens? The PR interval is like not so much changes in the PR interval. QRS is also normal. Okay, so but what you see, major one is the ST segment depression over here. Okay, and with a prominent U wave. Okay, so you can see the ST segment depression and a U wave. Okay, so that is what happens in the hypokalemia, but like a mild hypokalemia. Okay, okay, present immediately following the T wave. So the actual QT interval remains normal. If the U wave is erroneously considered as a part of the T wave, a falsely prolonged QT interval of 0.6 will be measured. So sometimes when you see the ECG, if you don't consider this as a T wave, if you take from U to the Q, okay, from all this way QT, you will think it as a prolonged QT interval, but it is not a prolonged QT interval. It's just a U wave representation. Okay, U wave is a part of the papillary muscles. Okay, papillary muscle problem. Okay, so that is having delayed of the, and it is getting represented more efficiently in the ECG. Normally the U waves does not get represented in the ECG. Okay, so when the hypokalemia becomes more severe and the plasma level of the potassium goes down to like around 2.5, then what happens? The PR is prolonged. You can see the prolongation of the PR interval. The PR interval is prolonged. QRS does not wide. QRS is still there. Okay, the PR interval is lengthened to around like 0.32. The ST segment is depressed. The T wave is inverted. Okay, and the prominent U wave is seen. Very prominent U wave is seen. The true QT interval remains normal. Okay, still the true QT interval remains normal. Okay, so this is what happens in hypokalemia. Okay, so hypokalemia, hyperkalemia, there is like additional thing that we have studied along with the arrhythmias. Okay, so that's it for this class. Okay, so thank you, see you in the next video. Okay, so bye for now.